So welcome to Fall 2023 Mini Mid-South. Here are social media QR codes. I think you all understand what the program is about here and that we're partnering this fall with the Sussex County Health Coalition. And my colleague, Christy Handley, represents them. There are no tests or grades, and you all are familiar with that by now. We did an earlier fall session that was more Newcastle County provider oriented. And this time we're doing a little bit more middle and southern part of the state. Just to remind, there's no CME, no CE, no CEU. This is purely for health literacy, your own education. Targeting middle, junior, and high school students and undergrad students to encourage you all to consider a career in the health sciences broadly, and hopefully in medicine, dentistry, nursing, so on more specifically. This evening, our presenter is going to talk a little bit about her journey to become a physician and hold a dual degree also in public health. And it's an interesting story. I just got a preview of it. And we also just want to remind that this is a safe space to ask questions. However, don't make them of a personal health-related nature. For those of you who complete all 6 sessions, you're eligible. You will get a signed certificate of accomplishment for attending all 6. And you'll be eligible to become a member of the Delaware Youth Medical Academy by writing a reflection paper. We started this last series, and know the questions for the reflection paper. I'm not going to tell you what they are now, and they will be different from what they were for the last one. I know some of you are here for a second series in a row, and that's great, but it'll be different questions. Fall semester now, we are talking about working in family medicine, and I'll turn it over to Christy to introduce this evening's speaker. Thank you.
Great. Thank you, Tim. I am super excited to talk about our next guest, Dr. Shalini Shah, who is a personal friend of mine and a great physician in Kent County. So Dr. Shah was actually born in Chicago, Illinois. She was raised in Allentown, Pennsylvania with her brother and her parents. She's going to talk to you a little bit about her journey through the educational system. So I'm not going to go into all of that, but she did become she is a partner with the Dover Family Physician Practice here in Dover, Delaware. She has been with them since 2011. She obtained her board certifications in lifestyle and obesity medicine. Her professional interests are preventative medicine, obesity, anxiety, depression, coaching, wellness, women's health, and physician burnout and diabetes. She has been participating in educating medical students and residents since 2019. She's the current undergraduate medical education director at Bay Health Medical Center, where she also has active privileges and takes care of her patients that are hospitalized. She serves as a chairwoman for the Department of Family Medicine at Bay Health Medical Center. She's the treasurer for the Medical Society of Delaware and is the Delaware AMA representative for private practice. She is a current member of the American Medical Association, Medical Society of Delaware, American College of Lifestyle Medicine, American College of Obesity Medicine, and the American Academy of Family Physicians. She also, in all of her spare time, volunteers at the Middletown YMCA board and the Delmarva Scouts board. She resides in Middletown, Delaware with her husband and her 2 boys. She loves to travel, read, dance. She's a great photographer, and she likes being a volleyball mom. So I'm going to turn it over to Dr. Shalini Shah.
All right, I'm going to go ahead and stop sharing. And just a reminder to the audience, please ask your questions in the Q&A. We'll answer some of them as we go along through this evening's presentation, and other ones we'll save for Dr. Shah to answer personally. All right.
Sounds
Over
great.
to you, Doctor.
All right, let me just share.
Great, we can see it.
Perfect. And There we go. All right. So this is just a quick PowerPoint presentation. And then I left a lot of time for questions because I like to do questions a lot more than anything else to give me some guidance. So again, my name is Dr. Shalini Shah. I am triple board certified in family medicine, obesity medicine, and lifestyle medicine. And this is just a brief history of my education and how I came, my pathway to becoming a physician. In my culture back in the day, and I was born in, I don't mind saying my age, I'm now currently 48, and I was born in 1975. I was pretty much kind of pushed into what I was going to do for my life. Medicine, engineering, and business were considered like the professions of choice for my family. And I always found science very interesting. Definitely had a natural affinity for the biological sciences. So I went to Penn State for undergraduate, and I actually went initially as a pre-med major. When you go to undergraduate school, you start talking to different people, taking different courses. And one of the courses I took was a nutrition course. And I was absolutely fascinated. And just a little bit of a side note, another thing, what made me very interested in medicine, especially my personal history, is that my father was during this time diagnosed with type 2 diabetes. And I really got interested in preventative medicine. And that's why I ended up taking this nutrition course, because nutrition is very much involved with being preventative to try to help reduce the risk of developing certain chronic diseases. I found that I really love nutrition. I thought nutrition science was right up my alley. It definitely involved a lot of biological sciences, but a little bit of chemistry. So I decided to switch. I went from pre-med to nutrition science, and I ended up getting my applied nutrition BS also with a minor in kinesiology, which is basically exercise movement at Penn State University in 1998. I then decided, after taking a lot of courses in nutrition, I had this one course that was public health nutrition. And I found the cool concept that you can actually change health by policy. And therefore, you can create system change to improve one's health. And I found this thought very fascinating. As a physician, you're working one-on-one to create sustainable change. But here is a practice in where you can now create system change, or you can create an environment that makes it easier for people to create healthy changes. So I decided that maybe I did want to go into medical school. So I decided, why not go for a master's of public health? I'm very good at being a student. I'm very good at taking tests. So I decided to apply for my NPH. I ended up getting admitted to University of California in Berkeley. And I did get my MPH in 2000 with a concentration in public policy and public health nutrition. During that time, I found that no, I really wanted to be a doctor. I really did miss some of the science aspect, the biological, the gross anatomy, the biochemistry, and I really felt that that was missing. I also had grand dreams of being the Surgeon General of the United States, and I saw that all the Surgeons Generals were all MDs or DOs. So I decided that I did really truly want to go to medical school, and so I did apply, and I ended up going to. When I applied and got in, it was MCP Hahnemann. They did a name change in the middle, and I graduated from Drexel University College of Medicine, and this was back in 2005. I then decided that, again, going with my whole motif and beliefs of preventative medicine, trying to encourage my patients, or trying to just encourage people to be well. The healthcare system in the United States, we are very much focused on acute care. We wait till you get diabetes and then we treat that. I really wanted to teach my patients what kind of healthy behaviors can you do to reduce your risk for developing these chronic conditions. And I really felt that family medicine really dovetailed with my beliefs. Family medicine also helped me with the whole spectrum of patient care. I can take care of all infants all the way to the grave. The normal quote we do is from the cradle to the grave. And I'll talk a little bit more about the breadth of family medicine. After completing my residency, I did decide further down to get board certified in lifestyle medicine, which just went ahead with, which really dovetailed nicely into my risk reduction for chronic diseases and using non-pharmacological options to try to help encourage my patients to live healthier. And then I also, for my own personal experience, went and got obesity medicine board certified. In terms of my work, my first job out of residency was at a federally designated health system called Family First Health in York, Pennsylvania, and I was there until 2011. Due to circumstances surrounding my family and my husband's job, we decided to relocate to Dover, and I became a physician at Dover Family Physicians, where I became a partner after 3 years. And I'm continuing to work there. However, I did go part-time this past year to be able to work a little bit more with medical student education, which is now my other part-time job at Bay Health, being the program director there. And Christy has already mentioned my other roles that I do, and this is all more my professional workload. So what does the family medicine physician do? Well, I like to say a little bit of everything. We're supposed to be the jack of all trades. And if you are someone who goes, oh, squirrel, you're probably really good for family medicine, because we do a little bit of everything. The other thing about family medicine is that we really understand the interconnectivity of the whole human body. And we also understand the interconnectivity of how we are as an individual and how we are in terms of systems that can affect us as an individual. We do acute care, we do preventative medicine, and we also do chronic disease management. In terms of our patient population, who do we see? We see all ages, and we see all genders. And depending on what you want to do, you can actually even subspecialize in family medicine, because it is sometimes hard to be an expert in everything. So there are fellowship opportunities in geriatrics, sports medicine, palliative hospice care, being a hospitalist, emergency medicine, rural medicine. There's also gender assignment specialties out there, and obesity. There's just tons of different opportunities with family medicine. And I do like that ability that if after a while I get a little bit bored, I can learn something else and become more of an expert in that area too. The other thing I really wanted to make sure is that you can have a life outside of medicine. This is a picture of some of the things that I find that I love and that helps bring me joy to my life. I am an amateur photographer, so most of these pictures, except for the picture of my family, is done by me. I also love to travel. So the one over on the left upper hand side is a picture of Bora Bora. And on the right is a picture of when we went to Alaska. And this is my family, my 2 boys. They are 13 and 16, and they love to play volleyball. So we are a volleyball family. I also am somewhat of a foodie. I try to eat plant-based foods, and so I really am excited about learning cooking. And so on the right bottom corner is me doing a plant-based meal, and that is tofu with some greens and some roasted vegetables. But I do eat meat on occasion, and so one of my favorite meat dishes is quesadilla, and that is at a Mexican restaurant. So I definitely like my food. And then my newest goal, and I feel like no matter what age you are, you should definitely have goals. And I am in the process of trying to get a black belt. And I do want you to know that, and I want everyone to understand that it's okay to strive for goals, and it's okay to not achieve them. The most important thing is to just keep trying, that it's not a failure if you learn a lesson from it. And this past spring, I ended up going for my black belt, and I unfortunately didn't pass. I am going to be trying again this coming spring, but one of my goals was to try to break a board. So this is a video of me at least achieving this goal. And I was pretty excited that I was able to do that after 3-4 years of practice. So that is the end of my presentation. I do want to open this up to questions at this point.
Okay, let's do this just a little bit differently this time, class, from the way we normally do. I'm going to ask Dr. Shah some questions first, and lead her through some stuff there, and then we'll spill into your questions. So we've heard you talk about your emphasis on nutrition. Can you explain to the class what metabolic syndrome is, the different components of that, and how, the hypertension, the diabetes, and the heart disease, how these things all interact with one another? One of the challenges that I find in explaining to pretty much anybody is that it's all connected. And what you do here can relate to there. So maybe that would be a starting place for talking a little bit more about the actual clinical practice that you do.
So that's a very complicated question, and I'm going to try to avoid being scientific-y, if that's such a word. But the main thing is that in the United States, we have a very processed eating patterns. And yes, we use the word, in nutrition, we use the word diet. And diet does not mean you're limiting yourself. It's not like a keto diet or a vegan diet. A diet just means what your eating patterns are. So I will say the word diet or eating patterns, and that's going to be interchangeable. So the American diet tends to be very high in processed foods, very high in meat or animal-based proteins, and that does lead to excessive calories. That, coupled with our other lifestyle thing, which is inactivity, we have computers. Most of us are having desk-sitting jobs. We're not farmers like back in the day doing very heavy active work. And so with that coupled with our eating patterns, we do end up having excessive calories, which then leads, and this is a simplified version, which then leads to excessive weight, and therefore not being a weight that is considered healthy. With this, the body does develop several mechanisms to try to help compensate for this. It does develop something called insulin resistance. It also, because the heart has to beat harder to try to get the blood everywhere, because there's now more muscle and fat mass, it has to beat harder, which can lead to hypertension. And then there's various chemical processes that can also add to the hypertension. And our eating patterns can also lead to plaque buildup in our arteries that can lead to coronary artery disease. Having elevated blood sugars in our body can also lead to something called diabetes, and diabetes in itself can also increase the risk of coronary artery disease, and coronary artery disease leads to a higher risk of developing either a stroke or a heart attack.
I'm sorry, keep going.
Okay, yeah, so sorry. So I was going to talk a little bit about, in terms of metabolic syndrome, what is happening with this is that through a lot of chemical processes, hormonal processes, where the body's trying to regulate, it develops this, well, we have this hormone called insulin. And insulin is actually a fat storage hormone. Among all of its roles that insulin does, it helps to promote fat storage. So if you tend to be a snacker throughout the day, every time you're snacking, you're releasing insulin. Insulin and how it works helps to also regulate our sugars. If we are at a weight that is not considered healthy for our body type, and that is based on multiple factors, there is not one size that fits all. And don't get me started about the BMI, which is a body mass index, which is a tool, but not the tool to assess weight and whether or not it's healthy or not. But when we start to have weight that is not healthy for our bodies, our sugars start to elevate. And then our body responds to that by secreting more insulin. Remember, insulin is a fat storing hormone. So while our body is trying to help control the sugars with the insulin, it's also promoting the one thing that's making the sugars go up anyway, which is being an unhealthy weight. And so after a while, the insulin is not able to control the blood sugar very well. And this is a condition that we call insulin resistance. So we first have hyperinsulinemia, which means insulin that is being produced more than what it should, according to our guidelines. And then we develop insulin resistance because now our body is not, the insulin's not working as well as it used to. And once we start developing insulin resistance, that's when our blood sugar will start to go up. And when our blood sugars go up in our bloodstream, it starts to interfere with other bodily functions. It can start attaching to the nerves, which can cause something called neuropathy, which is the numbness and tingling that can occur with diabetics. And that can cause sometimes a lot of pain, a burning type pain, primarily in our hands and our feet. First starts in the feet. It can also attach to our cardiac muscles. It can cause very sticky situations inside our arteries, which then can also lead to more plaque buildup. And plaque buildup can lead to a stroke or a heart attack. Can be one of the reasons for a stroke or a heart attack. It's not the only reason. Was that, I don't know. I mean, I can go on a long time.
No. That you hit it all. It is one of those terms that I don't know, I feel like sometimes it's almost a loaded term that you pull out at a cocktail party, or
Yes.
that perhaps kids hear and they go, I mean, metabolic syndrome sounds super scary all on its own. And when you break it down into constituent parts, at least you demystify it a good bit. The other thing that in previous mini-med series, we've heard about the gut microbiome and that whole sort of frontier of understanding how what's in your gut impacts the rest of you. Care to talk about that at all?
I don't have much familiarity with it. I know that there is lots and lots of research discussion about it. And this is where I love my people in the media, but this is where I think sometimes the media can not distort, but say things that may not be ready for prime time. So there is a lot of research going on in how the microbiome can affect many different things. There is some hypothesis out there that the microbiome can be implicated with obesity. There is some in terms of just overall gut health can help with cardiovascular risk factors or inflammation. And inflammation now is like a big buzzword that I need to get my inflammation markers down. But we really don't have very good studies that actually tell us that, yes, by reducing your inflammation markers, it does reduce the risk of you having a heart attack. Because in the end of the day, what do we care about? I care not having a heart attack. I care not having my foot chopped off because of my diabetes and I need to get an amputation. I care not to have a stroke. And those are the endpoints that we're looking at. And this is what's really important with evidence-based medicine, is that you need to be doing research, but then you need to correlate that research with endpoints that are clinically significant. And I'm going to take the cholesterol, which is not the microbiome, but cholesterol, I think a lot of us can identify with because everyone knows that high cholesterol can be a risk factor for heart disease. But in the end, do we care about cholesterol? No, we don't. We care about the heart attack and the stroke. So we're using the cholesterol as a surrogate or as a possible risk, but in the end, we need to make sure that we are reducing the risk of having a heart attack or a stroke, because that is what's really important. If my cholesterol, and we know people who have cholesterol in the 300s and they never have a stroke. We know people who smoke for many, 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 many years and they will never develop a cancer. But when we're talking about population medicine, when we're talking about population and public health, we are looking at society and we're talking about risk and risk reduction. So when it comes to biogut health, I don't know yet if there's really good evidence-based medicine that, one, how do we alter it? And if we do alter it, does that clinically make significant changes on clinical outcomes?
Right. Good
Does that
answer.
make sense?
Good answer. Now I see that you have your hand raised. Please put your question into the Q&A for us. All right, so what aspects of practicing medicine do you find the most challenging?
I would say that not being able to treat my patient the way I feel as a physician they need to be treated. Because there's a lot of other cooks in the kitchen. So
and a lot of supervisors overseeing all the cooks.
Yes, exactly. You know, unfortunately, healthcare in the United States is quite complicated. And I don't think it has to be that way. Now, unfortunately, you would have to burn the whole healthcare system and probably start from scratch, which no one is going to want to take that risk because they've tried to fix it and there's just too many players involved now. And there's winners and losers with any kind of decision. And unfortunately, that's the reality of just being, that's life. But I would say that that is the most frustrating. You know, when I feel a patient I really try to practice evidence-based medicine. I try to make sure that I'm up with the current guidelines. And when I truly feel that a patient needs X, Y, and Z, or being allowed to give my patient the time to talk about lifestyle measures to see if that's something that is compatible with their view, I'm being told either by an employer or by insurance company or even by the government that certain things can't be done. And that's the political way of saying it.
Right. Let's see. So Abigail goes a little bit deeper and she's asking about what are the challenges of family medicine and what are the benefits? So I guess that's a personal and reflection question and a patient reflection question. Challenges and benefits.
Well, the biggest challenge, again, is just what I alluded to. It's the interference. Again, insurance companies tend to be a big barrier. Right now, we have barriers because for once in a long time, we are having shortages. Something that we never, in a country that is so used to abundance, and now having shortages and having to pivot things and having a patient population that's not used to this can be very challenging in itself. And I'm not talking about just shortages in medications, but shortages in physicians, shortages in staff to help the physicians. I have had patients who are needing different testing procedures or surgical procedures, and they're being pushed out 4 or 5 months when before that really was not the reality. And now it's becoming the reality. The benefit, as Christy can probably agree, it's my patients. It's the relationship with my patients. My patients, and you know, again, I've been fortunate to be a part of their life for 12 years. Some of them I have seen as infants, and now they're 12 years old. Some I saw them when they were, 12 or 13, and now they're come back to me and ask Dr. Shah, can I shadow you because I'm interested in going into medicine? And then on the flip side, I get to hold a patient. Well, it's my both of them are my patients, but this wife whose husband passed away, who was also my patient, and to just be there and support the wife going through this grieving, which is a normal process, and just being supportive and just being a human. And I'm honored to be a part of their lives in all stages of their lives. I'm a firm advocate that we will all pass away at one point in our lives. I mean, that's just, to me, an inevitable. And my goal is to make sure that my patients know that I will help them according to what their beliefs are, and support them based on their beliefs. And know that there's always multiple ways to, as I say, skin a cat. And to let them know what their options are. And if they decide that hospice care, palliative care is the way to go, I'm okay. I'm there for them. I will support them with their decision, and just helping them with that, and being there. That, to me, that's the best part about being family medicine physician. And then I get to talk on my soapboxes. Some of my patients know what buttons to push, and then I'll get on my soapboxes, and then they'll start laughing. I mean, it's just the relationships.
I hear you. So I'm going to ask one more question. I'm going to turn it over to Christy to pick some of the questions. So Emily Mercado, I think you have a future as an MD, MPH. You've asked a great question. When you're identifying a case, what the patient needs or has, do you search for it individually or in groups? Or is it sometimes one or the other? Can you see that question? If you go to the Q&A,
I'm seeing it. I'm just not sure if I understand it. What do they mean by searching for it?
What a patient needs. When you're identifying a case, what the patient needs or has, do you search for it individually or in groups? I have to confess now that I'm reading it with more deeply, I too. Emily, can you type in here and tell us a little bit more about what you're asking for? What I was initially saying is, are you looking, if you have a case presentation, are you looking for general population who has this set of symptoms, and does this generally say, you can take these potentials out of the thing, but keep these in, doing the differential diagnosis, which would be a great thing for you to explain to people too? Or are you looking at it purely on an individual basis? So anyway, Emily, tell us more about what you're asking, but tell us about what differential diagnosis means.
I think the best way is to give an example. So usually when you go in to see a physician, the nurse or the MA, who is a medical assistant, will bring you in and ask you, what are you here for? And let's say you come in for a cough and congestion. Tis the season, so we'll do the cough and congestion, which is the #1 reason why people go to family medicine doctor, by the way. Anyway, so automatically, when I see that on my electronic health record, we no longer have paper charts, but electronic health record, and I see cough and congestion, in my mind, I am thinking of actual diagnoses that can cover those symptoms. And then based on my list, and it can be, an upper respiratory infection, it can be allergies, it can be pneumonia, it can be heartburn, reflux, it can be tuberculosis, it can be aspergillosis, it can be many other less common things. I'm starting to go to like uncommon things. And we look for, we rule out, we try to make sure that we rule out the worst case scenario. So in this circumstances, I would say that probably the worst case scenario with a cough and congestion would be a pneumonia. And then based on my exam and my history taking, I am now making my different, now I think if I have a list here, and based on the answers to my history, to asking questions, and then also based on my physical exam, I then will go ahead and say, what is the most likely diagnosis? And then make recommendations based on that.
Not to in any way diminish this down to a game, but how much does this sometimes feel like you're playing Clue? Where it
is kind of like playing Clue, right? Because you need to get clues from your history, and then based on your history, that helps to guide your exam. and you already have a list of, to me, it's test taking. If you kind of think about it, you have your you have a vignette, right? I always read the answers first. And then based on the answers, I look, the answers is your diagnosis, right? And then you're looking at evidence to support which diagnosis it could be.
All right. Well, and it from sort of my position, it is one of the major reasons that when we as patients go to our healthcare providers, we're as absolutely candid in our symptoms and circumstances as we can, the more genuine, the more comfortable you can be in explaining what's going on and what went on before, and maybe even relating that back to stuff that went on even earlier than that and how that impacts things now. It helps build that story and gives your healthcare practitioner more ammunition to support, whatever conclusion they're reaching. Anyway, Christy, I promised over to you. Your turn.
I always like these questions. So talk about what your work-life balance was during your residency and then how your work-life balance is now as a physician.
Let's see. It's kind of hard to describe that because obviously I have different life then and there. But during residency, it definitely is time consuming. I won't lie to you about that. But I also, it was just me and my husband. I didn't have a child until my second year of residency, and he was just an infant. And I'm very fortunate. I had a very supportive husband. My parents were 20 minutes away, so I had a lot of support with my, with my baby. And so, and plus I had a really great family medicine program. That was one of the reasons why I chose that residency, was the support that I knew I was going to get from the program. But it definitely was tough. I mean, there were days where I would be on call overnight. But I was younger, and at that time, it didn't seem any different than pulling an all-nighter for an exam when you're an undergrad. But it definitely was tough, but I thought it was doable. It did change because, when I became a attending physician, got a real job, because I'm a family medicine physician, and you can, as a resident, you have to go through a program. So they are basically telling you what your hours are going to be, versus an attending. If you don't like those hours, you can find a new job. So, and so, it usually is typically 8 to 5, 9 to 6, 9 to 5, depending on where you practice. I did do hospital work. I did go part-time this year, so I no longer do hospital work. But when I did hospital work, I was on call for 24 hours for a whole 7 days. Now, what that meant is that I carried a beeper every day for 24 hours for a whole week. I didn't have to actually go into the hospital all the time. Where I practice, we had hospitalists that covered us from 7 p.m. to 7 a.m. in the hospital. So if we had a patient that ended up not doing well, or if there was an admission and it was one of our patients from our practice, they would take care of it. So then I would just have outpatient phone calls. And it's a little bit different because when you're the attending physician, the buck stops at you, versus when you are a resident, you always could go and talk to your supervising physician. So that also was, the level of responsibility was different. Did that answer the question?
Very well. Thank you.
Yeah.
How long did it take you to become a doctor?
So typically it takes 4 years of undergrad, then 4 years of medical school, and then anywhere from 3 to 5 years for residency. For a family medicine residency, it's a 3-year program. So that's 11 years total from high school graduation till you become an attending practicing physician.
Someone asked, if I want to go into nutrition or the dietitian field, what types of courses and certifications should I start with?
You would need to get, first of all, a high school diploma. Then you would need to go to undergrad. And you would get a BS in nutrition. And then after that, and this is where I can't give you 100% because my path did diverge from here, but you would go for an RD apprentice, like an internship. And it's going to be and then after you do your internship, you sit for an exam of some sort to become a registered dietitian, otherwise known as an RD. And an RD is different than a nutritionist. Anyone can call themselves a nutritionist. Anyone can call themselves a nutritionist. An RD goes through undergrad, does an internship, and then is actually registered dietitian. They have that RD background. So
Thanks for explaining that.
yeah.
If you could go back and talk to your younger self applying to medical school, what's one tip you would give?
Those questions are always so good, but so hard to answer. Not be afraid of failure. Because I think there were 2 to 3 times where I postponed applying to medical school because I was afraid to fail. And I think that if I would have continued, it's okay to fail. It's okay to fail. And I think that would have been one advice I would have given myself. So I would be more willing to take chances. I still like the sure bet, but I'm a little bit more okay with failure. So
I'm going to ask this question because you talk about, and you've mentioned it a couple times, about a hospitalist. Can you tell us what is it that a hospitalist does?
So in terms of medicine, it really has changed over the last few decades. There used to be when you had your doctor, the doctor would be able, there's 2 arenas or areas of practicing to become as a physician. You can practice in an office or you can practice inside a hospital. So that would be outpatient or inpatient. So outpatient is in office, inpatient is in the hospital. Traditionally, back in the day, mostly all doctors did both outpatient and inpatient work. So a typical day for a primary care physician would be that, they would round on their patients in the hospital. They would go then to their office, see patients on the outpatient world. And then if there was any admissions or anything that happened during the day, they would then go back to the hospital to take care of those patients again. Because medicine is becoming so specialized, then there became and also the quality of life, this is quality of life for the physician, there became a split. And now there's doctors that are primarily just outpatient, so they only practice outside of the hospital. And then there are doctors called hospitalists that practice just in the hospital. And so these are usually either family medicine or internal medicine doctors. Majority is internal medicine, but as a family medicine doctor, you can be a hospitalist. And you basically, it's shift work. You're working usually 12 hours a day. And it's like 7 to 7, 9 to 9, depends on where you practice. And it's shift work. You go in, you put in your shift, you leave. And they're responsible, depending on what kind of hospitalist they are. There's even pediatric hospitalists now. So that is children doctors that just take care of the kids in the hospital, and they don't do outpatient at all. And again, they pretty much can do anything. There's even critical care doctors that are hospitalists, and then they're the ones that take care of our most critical patients.
I'm a high school student and passionate about being a physician, but I'm not sure what to specialize in. How do you make that decision?
I would think that at this point, you don't need to worry about it as a high school student. You're going to have many years between then and there, and you're going to know your people as a 3rd year. So for typical medical school, it is a 4-year program. The first 2 years are didactics. You're sitting through lectures. You're learning gross anatomy. You're going to be dissecting a human. You're going to do biochem. You're going to do pathology. You're doing pharmacology. You're doing microbiology. And then probably some other ones that I can't remember off the top of my head. But it's basically 2 years of lectures. You do have a little bit of patient care where you may go into the hospital or into an office and learn how to take a history. You will also learn the basics of a physical exam. It's not until your 3rd year and your 4th year, which are considered your clinical years, that you actually will then go and rotate through all the different specialties in medicine. So typically, and this does vary based on what medical school you go to, but typically you're going to spend so many weeks in the big 6 specialties in medicine: family medicine, internal medicine, surgery, pediatrics, OBGYN, and psychiatry. And you get to try them all out. And it really is true. You'll know your people when you are with them. There is actually a book. I can't remember the name, but I can look it up and then send it to Christy, and she can forward it. And it's basically it's a journal turned book of a third-year medical student and how her journey was going through all the different rotations. And she found her people. It was emergency medicine. So, and you just, if you know your core values and your characteristic, you're going to find where you're going to go. And if you find that you like a little bit of everything, then you belong in family medicine.
So along that same line, did you ever consider any other specialty in medical school?
Yes. So I went into medical school thinking I wanted to be a family medicine doctor, but with my history and passion for diabetes, endocrinology definitely was an interest and passion of mine. And also allergy. So being an allergist was also very interesting for me because of my own personal experience with allergies. And so I was thinking about that, but I was a little bit older student going to medical school. I did, do 2 years for my master's of public health. And I really just could not think of doing 3 years of internal medicine residency and then doing an additional 3 years of a fellowship. So that's 6 years of training after medical school. And I just was done. And then in the end, I really thought about what my core values are. And I see a lot of diabetics as a family medicine doctor. And I see a lot that every day I see 2 to 3 diabetics. And I'm very comfortable with my diabetes. And I knew that if I didn't know if I wanted to just see nothing but diabetics with a few thyroid and some unusual endocrine abnormalities all day long. And so then I decided, no, I needed to do family medicine, that I can still do a lot of diabetes, but I didn't have to be an endocrinologist.
One thing you just mentioned, you talked about your core values. How important is it to truly understand what your core values are when you go into medicine?
It's important because I hate to say this, but you're going to see things. You're going to also have experiences that can really challenge those views. And if you don't know your why, if you don't remember why you got into medicine, you're going to get disillusioned or burned out pretty quickly. And again, I don't want to sugarcoat being in medicine because there are challenges in it, but being a physician physicians have a higher rate of suicide. Okay. So it's a challenging profession. And I think that if you don't understand your why to be your North Star, you're going to lose yourself and, a higher risk of depression, higher risk of burnout. And on top of that, you can make mistakes and maybe harm somebody depending on the circumstances. So I do think knowing your core values and understanding your why is important. If you're going into medicine for the money, it ain't going to happen. There's many other professions out there that you can make money.
It's funny because we did have a couple questions about, will I get rich from being a medical professional or a physician and those kinds of things, but we took care of those. So I'm interested.
I can give you I don't know what you said, but I can give you my 2 cents.
Go for it.
If you think about it, my colleagues who I went to undergrad with, they went straight into a profession and they were earning, like engineers. They earn a good salary. They are now putting money into their 401k at age 22. I did not have a real job until 34 or 35. And there's something called compounding interest. I lost not 14 years, but over 10 years of compounding interest until I became an attending. And by then, I already had a family. So even though my cost of living went up, my expenses went up right with it. And so I don't personally think you're going to get rich. There are other things to do, if your why is to get rich, I don't think being a physician is going to be a way to achieve that why. That's my personal opinion.
Answer on that. We really do appreciate that. You talked
That is some people's whys.
It is. Some people do have that why. You talked about burnout, and I think that's a really great point. And just reading recently about, physicians have a high suicide rate, which really honestly did surprise me, but I do understand it. One of the questions is, how do you deal with burnout?
I have no problem saying that I had it. I experienced burnout back in 2019. I started having it was hard, and this was before the pandemic. We're talking 2019. Trying to, I was a full-time practicing partner at my practice, having two boys. One was starting to become mouthy, teenager, at least mouthy for me. Probably not mouthy in the grand scheme of things, but mouthy for me. And unfortunately, it ended up being, I did not like working in the hospital. To me, it's a high stress period because I'm always afraid, like that beeper, when it goes on, I get PTSD. I just get all tensed whenever I have the beeper on me. So I'm basically not relaxed for a whole week until that beeper goes to somebody else. And so, in the beginning, I'm okay, but my family, my patients, even my staff who I work with, they knew that as the days went on, I was getting more and more tense because I just could not relax. And so I definitely had burnout, and I felt that it was definitely affecting just all different avenues of my life. And so I went through coaching, which is why I really love coaching. Mental health is a double-edged sword as a physician, because it's easier for us to counsel our patients on mental health. But in this society, and especially in the physician land, mental health is still considered a negative. It means you're weak when you start talking about it. And then just recently it got changed in the state of Delaware. But before, if you were a physician that was seeking professional help for mental health, that is technically was reportable. Now that did get changed, but that is another barrier for physicians to be looking and seeking help. So, but yeah, so for me, in terms of burnout, I ended up making some changes. I ended up having a scribe temporarily, which was, one of the things that I really did not like about being among other things, but I don't like writing. I never liked English. I hate writing. And so writing notes was always like the least favorable task that I had to do at the end of the day. And I had a scribe. It was lovely. I could actually focus on talking to my patients, and my scribe would take care of all the documentation. And my notes were definitely better for it too. And with the pandemic, that did change things a little bit. And with that, it caused me to have more time to self-reflect. And I also started having a lot of regret because I did miss a lot of my kids' lives, I felt. And so I decided that I can't change the past. I can't go back and get that time back, but I can make changes now to have the time that I am having. So that is why I made the decision to go part-time this year. My oldest is 16. He's going to be going to college in 2 years. So even though he is not a huggy type kind of boy anymore, at least I know that these 2 years I'm going to be trying to spend as much time as I can being a volleyball mom, cheering them on, trying to be at their events, just trying to be supportive, because I know they're going to be leaving me, which mama guilt is real. There's no but dad guilt, but mama guilt is real.
It is a very real thing. I agree with you. Okay, what was it like rotating in the different specialties in the medical school? Did you have trouble with being confident? Do you have any other tips?
The thing is that now that I'm an educator and I teach medical students, it's okay to not, I mean, you're not supposed to know everything. You're a medical student. And I think it's some of the expectations that we put upon ourselves that we're supposed to know everything as a third-year medical student. I'm going to admit to, I tell my students all the time, I've been a practicing physician for the last, I don't know, since 2008. So I can't do the math off the top of my head, but I think it's been not quite 20 years, but we'll say 15 years. And I'm not going to say that I know everything. If you know everything, if a physician tells you they know everything, I would be scared, very scared. Because there's no way, the way science is coming, the way sciences are evolving, there's no way you can know everything. So I try to, you have to normalize it because it's a mindset. You're not supposed to know everything, and that's okay. The other thing is that when you're a third-year medical student, you know where are the good rotations versus the not so good rotations. I knew that I did not want to do surgery. I knew that flat out, had no qualms about it. Surgery and me were not going to be, you know, a connection. But I also knew that there was this one rotation site where if you were not going to go into surgery and you wanted to have it easy and you didn't want to be have a painful experience, that was the site to go. I had the best experience. The attendings were kind, the residents were kind. I learned a lot. I got to be in surgeries that most humans will never see. It was a great experience and I learned tons. But they didn't expect me to become a surgeon. So I wasn't having that, I didn't have that kind of expectation for myself. And so I do think that some of this is going to be a mindset, and confidence is really, unfortunately, something that you build within. And you're going to have some of those attending physicians. We all know that there's those, not even forget about it. Physicians are humans. And we all know that there are humans that are not as supportive as they can be. That's their problem, not yours. Except if they have your grade in hand, but there's ways to work around that.
Tim,
I'm going to jump in here and grab one of these questions, Christy. What would you say is the main difference between a physician and a nurse? How do the responsibilities and impact differ?
That's a little bit hard because I don't know exactly all the responsibilities of a nurse. And of course, when I'm saying a nurse, I'm not talking about a nurse practitioner or a clinical nursing, CNS. I forgot what the S stands for, but a clinical nurse something. So a nurse is really, I don't know how to explain it. I know that I give orders. The nurse really, he or she is going to be the one that gives the injections, does patient education, make sure that the patient is real. Unfortunately, in our medical system, they're the ones that have the relationship in an inpatient scenario. So in nursing responsibilities change depending on where they're practicing. So like in the hospital, one nurse is assigned 2 to 3 patients, maybe 3 to 5, depending on where they are and the acuity of the patients. And they are going to be the ones, along with a nursing aide, which is responsible in terms of toileting, making sure that they're getting their medications, making sure the IVs are running smoothly, if they're needing toileting or bathing or eating. More of the nurse's aide is going to do more of that chores. Unfortunately, nurses do a lot of documentation and they ask a lot of questions, versus a physician, because when we're seeing patients, we're not like in a unit seeing only 2 or 3 patients. We can have up to 20 patients throughout the hospital. So we are running around seeing our patients. We're the ones that put in the orders. We are the ones that have been trained in pharmacological and ordering the medications, while the nurses, they're really trained on how to administer the medications. Does that make sense? But I always think that we are a team. There is no way that I can do what I need to do without my nurses. They help are the eyes, the ears, the hands, and they'll let me know how the patients are doing, so then I can make appropriate dietary orders or appropriate physical activity orders or medication changes. And if a nurse calls me and they're saying that they're concerned about a patient, I stand up and listen and I come down, because I will only see them for like maybe 15, 20 minutes. They're with that patient all day long. Now, in an outpatient scenario, nursing can answer questions. They can also give the vaccines or shots, depending on what's being done in that office. They can do the intake for the patient in terms of the blood pressures, heart rate. The medical assistant now is doing more of those duties nowadays. Again, we're the ones that are responsible for the orders, medication adjustments. And technically in an office, even a nurse or an MA cannot do anything without an order from the physician.
The other thing that I would add on to that, based on comments from other types of nurses that we've had, as speakers for MiniMed, is, Doctor, as you pointed out, there are a lot of different levels of nursing. There are CNAs, there are LPNs, there are RNs, there are NPs, there are DNPs. And it really, you need to be very precise in, and asking and answering a question like that, because part of what has happened in nursing, especially over the last, maybe, in my opinion, 15 to 20 years, is that nurses have expanded the scope of their license, and the more they practice to what's called the top of their license, the more difficult it is to distinguish between what a nurse does, what a physician assistant does, and what a doctor does. But I believe that the important point, the much more important point, is that it's a team effort. That's really where the rubber hits the road. I mean, physicians, I think, are capable, but probably hard pressed to operate in the absence of all these support people, nurses among them, and phlebotomists and med techs and lines and tigers,
respiratory therapists, speech therapists. And that's why I did make a key distinction that I'm talking about RNs particularly. Not including NPs or CNSs, and when I was talking about a nurse. So
CNS, certified nurse specialist.
That's it. Certified
Thank
nurse.
You had to say it another time for it to click in my mind. Hey, I've got another question, which really harks back to your original sort of interest. What are some common nutrition misconceptions that you have to explain in terms of metabolism? What are some things that we've just been taught wrong?
Carbohydrates are bad. A typical carbohydrates have gotten such a bad rap lately. It's definitely it definitely has been the bad child lately. I do think that people need to understand that there's 3 macronutrients, and these are the ones that have the calories. It's your carbs, carbohydrates, fats, and then your proteins. And you need all 3. A diet that eliminates one of them is not considered a healthy diet. It is the proportion that we do need to be concerned about. And it's the type of nutrient and how you're ingesting it. And then another and I can go on about that, so I won't keep going on about that. But then the other misconception is that supplements are the way to go for nutrition. I just don't think that at this point we have the ability to take an apple and break it down into a bunch of pills. There are so many phytonutrients, phytochemicals, antioxidants, and fiber in an apple that can never be replaced by a supplement. And so I really encourage my patients. There are a few supplements, and again, I'm not giving medical advice, but there are a few supplements that I do recommend based on personal risk factors. But overall, you really need to eat healthy foods to get the nutrients that you need. Right. And there is not one and some of the misconceptions, especially with the media, butter is good, butter is bad, eggs are good, eggs are bad, is that we are in a society that we like to think of the world as black and white, and we just don't understand the shades of gray. And I do think that your dietary or your eating patterns, you got to find what works for you, and you're going to know by how you feel, how you move, how you think, or those are the most important things. And then some other biochemical markers.
Right. Hey, I didn't ask you about C-reactive protein.
Oh.
See, forget I said that. Christy,
Yes.
over to you. You've got the last 3 questions.
So, what's it like to work with the undergraduate medical students at Bay Health?
I love it. One, they keep me young. I get to learn about all the new social media stuff. Not that I'm going to do any of it, but at least I learned about it. So it makes me more with it with my kids. But they keep me on my toes. They're expecting to know evidence-based medicine and the most current clinical guidelines. And so it motivates me to keep learning. And then the other thing is that sometimes they look at something with a different fresh, when you're used to doing something, you do it over and over and over again. Sometimes you have to have that other pair of eyes going, well, did you look at it this way? Or what about this? And then you're like, oh, I got to think of it that way. And so I love having medical students. I think that they keep me on my toes, engaged, and it actually helped a lot with my burnout.
That's great to hear. I plan on attending PA school, then going to medical school. Are there any shadowing opportunities that you know of?
I would say, why are you going to PA and then medical school? Is one question I would say, because that's a lot of schooling. Shadowing opportunities, there is a program called Apollo. It depends on where you are, if you're a high school student or undergrad, because I think the Apollo program is for our high school students. And then if you're a college age student, I know that Bay Health has a shadowing externship opportunity, and I believe Christiana and BB would also have opportunities also. The other thing is that if you have a physician that is your primary care physician, ask them.
Yeah, that's a great idea.
If you wanted to be an NP, do you recommend just being a doctor since it's the same amount of years?
I unfortunately cannot comment on that because I don't know how long it takes to be an NP.
Yeah, that's one of those loaded questions. I mean, I certainly get the logic there. There's another question here, sort of a closing question that goes along with shadowing: research opportunities that you know of.
So I personally don't do any personal research, but main thing is going to be if you need to get connected with a college campus, and they're going to have your best research opportunities. So if you're already at college, looking around at your different professors and seeing if there's any kind of research opportunities, if you do have any connections, or if you end up shadowing at Bay Health, there are physicians that do research, and they're always looking for assistance. And that's another way to do some research opportunities.
Right. I'm going to drop a link in the chat in the main chat, if I can. Everyone, there we go. There is a program, you all, called it's the NIH All of Us Research Program. It doesn't exactly scratch the itch of getting you doing research, but it allows you to become a part of research. Historically, well, deep historically, medical research was done on white men. And that has led to, in at least this white man's opinion, some fairly profound misunderstandings about how things work for women, for people of color, for people of different genetic disposition. And so all of us is trying to reach out to all age, genders, race, sexual orientation, and whatnot. And it's a study that you can become a part of. And in becoming a part of something like this, you can indirectly get exposed to what it is to do research. The full disclosure, the Academy DPHA is an all of us research partner with NIH, but that's why I took this opportunity to mention it. All
That's a
right.
very important point. Yes.
Yeah. Do surgeons need more years of school, or is it the same amount? So as Dr. Shah mentioned, there's residency and then there's fellowship. And it is that fellowship that adds years on top of, and it depends what kind of ultimate practice you want to do, how long your fellowship is. I think you said for you it was 6 years, or it would have been 3 more years at least. So it's a long road. Fellowship is it's a big deal.
Well, if I can interject, for surgery, it's actually a 5-year residency program. So that is different than family medicine or internal medicine. And then if you wanted to subspecialize in surgery, then that may be additional years on top of the 5 years. And then there are surgical specialties like urology, I think CT surgery, where you don't do a general surgical fellowship. You match right into that specialty. Do we have time that I can talk about the match process? Because I think that's a little bit that they may not know about.
Absolutely.
Okay, so there's something called a match. And so when you are towards the end of your 3rd year, beginning of 4th year, you're going to have to decide where you want, like what specialty do you want? Family medicine, internal medicine, urology, OBGYN, peds. I mean, there's many different options. And then you have to select different schools and you have your interviews for them. And this typically happens during your 4th year, usually starts around the end of October and it can go all the way to the beginning or end of January. And that's your interviewing time. Then by March, usually it's like within the first week of March, you need to rank the programs in order of preference where you would like to go. And you have to rank your top choices number 1, and you can rank up to, I don't know, I ranked 10, but I think you can rank more than that if you wished. And then the programs, they're ranking you guys or ranking us based on their preference. And then there's some mysterious computer somewhere in the world that takes the list and then they match them. And so there is a day in March, it's called Match Day, where all medical students open up their envelope. Well, sorry, that was for me. I think now they get an email. But for me, we all met in the auditorium. We all got our envelope and it had where we matched to. And we all opened at the same time and we found out where we're going to go for residency. So there is a chance that you may not match in the specialty that you want to match in. You will find out before match day if you did not match. And if you do, then you have to do something called SOAP, which is where you have to scramble for a position. So that you will have a position to go, you will have a residency when it is actual match day. So that is the process. And so then on match day, all physicians will, majority of medical students will know where they're going to go for their residency. There are medical students that do not match, and they will have to then go back into the pool for next year.
Right.
Because we don't have enough residency programs to take care of all of our med students.
Although Delaware's trying.
We're trying. Yes, we are.
Bay Health and BB's new residency programs are definitely steps ahead.
Yes.
I wish that Delaware had more fellowship opportunities so we weren't losing great minds, especially Delawareans who have gone to Jeffrey PCOM and come back. They do the residency, but then they're going into some track that they're going to need to do a fellowship, and we don't have those in Delaware, and they go elsewhere and we lose them.
Well, Bay Health did have, we just have a now HEMONC fellowship. We are accepting our new first class of fellows this year. They'll be starting in July. And we are putting in an application for a GI fellowship at Bay Health.
Now tell people what heme-onc is.
Hematology oncology. They're the blood and cancer doctors.
Great. Thank you very much.
Mhm.
Well, it looks like the questions have subsided. Doctor, thank you so much